All right, so today we are talking about the practice of clinical diagnosis. So what is diagnosis? So in diagnosis, we're trying to classify the individual person's problem and we're trying to label it accordingly. So there are a number of tools that we use in clinical psychology to classify, to diagnose abnormal behavior. So you can see this image here, the Diagnostic and Statistical Manual of Mental Disorders, the DSM-4. The TR stands for text revision. The DSM-5 is supposed to be coming out this year, so some of these things will change. So just keep that in mind as we move through the semester. So with the practice of diagnosis, we are looking at some kind of prognosis. And prognosis basically means that with diagnosis, we get a description of the individual's problem, and then prognosis predicts the problem's future course. There are several criticisms of diagnosis as well. So first, diagnosis is tied to a medical model. So that means that we have a history in clinical psychology of looking at what's wrong with people, right? Instead of perhaps focusing on the more positive aspects of human nature. The diagnosis also might lead to labeling theory or problems with labeling. So if you've ever heard of something called a self-fulfilling prophecy, let's say that we have a small child and we say to this child, okay, I am going to diagnose you, I'm going to label you as having a learning disability. And then the child starts to internalize or take on that label, saying, well, I don't have to try hard in school because I have a learning disability, so I'm never going to get it anyway. And then the child starts doing those kinds of behaviors that basically fulfill the label. So the child starts giving up on things and saying that, well, I have a learning disability, so it's not a big deal. It can become a self-fulfilling prophecy. So several criticisms of diagnosis. Additionally, diagnosis, we're trying to put people into these categories, but as I mentioned in the lecture on historical perspectives, every person is unique, and it's great that we want to be able to put people in these neat little boxes, these neat little categories, but in reality, that's not really the way that it goes. Oftentimes, individuals will have multiple diagnoses. So sorting patients into diagnostic categories in the DSM, that's basically what this book does. It provides different categories which we'll talk about over the course of the semester. And a categorical approach basically tries to divide individual symptoms, problems, classification into discrete bins or discrete boxes that we can sort these individuals into. A dimensional classification, on the other hand, looks at dimensions of pathology, based on this understanding that rarely do you see a client who is a textbook case. That means a client who fits perfectly the description that is given in the DSM, especially when you work with individuals who have personality disorders. So for example, let's say that you are looking at someone who has obsessive compulsive disorder. Maybe you have one person on this continuum who is very detail oriented. So they might show a hint of OCD. Then you have another person on the same continuum who's mildly obsessive. And lastly, you have a person who has serious problems with obsessive behavior. So if you look at it from a dimensional classification, the first person is probably the least severe. The third person probably meets diagnostic criteria for obsessive compulsive disorder. So the way that the current DSM diagnoses individuals, it uses a 5-axial system. So on each of these axes, you might have something noted there. If you do not have, let's say on axis 2, a personality disorder or intellectual disability, general medical, you would say that this axis is deferred, okay? So that means that there's nothing on there. So first, on axis 1, this is your primary clinical syndrome. This is basically the reason that you are seeking treatment. So something like major depression, some kind of anxiety disorder, eating disorder would go on axis 1. On axis 2, only personality disorders or intellectual disability. Those are the only things that are included on axis 2. And the reason that personality disorders and intellectual disability are separated out from axis 1 is that these two things, personality and intellectual, tend to be long-standing complications that are not amenable to treatment so much. So they're not very responsive to treatment. The personality disorder is part of you, part of your person. Intellectual disability is something that you'll have for the rest of your life. There are certainly ways to deal with it, but again, these are long-standing problems, whereas something like major depression, which would go on axis 1, is very responsive to treatment. And just because an individual is depressed right now does not mean that that individual will be depressed for the rest of her life. On axis 3, we want to know, are there any medical conditions that could be related to your presenting problem? So for example, have you just been diagnosed with terminal cancer? That might explain why you're feeling anxious or why you're feeling depressed. We would note that on axis 3. On axis 4, we want to know what is going on in the social environment. What is going on if you have problems with your primary support group? Are you having financial problems, access to education? Are you living in poverty? You don't have access to health care. Maybe you just experienced the death of a loved one. All of these things are relevant in helping us to get a full picture of the client's presenting problem. And then on axis 5, we have what's called the Global Assessment of Functioning, or a GAF score, G-A-F. The Global Assessment of Functioning score is a number. You can use this chart here, a number between 1 and 100 that gives you a snapshot of how the client is doing. Hopefully this number will change, right, as you move through treatment with your client. So your client might start at, let's say, a 55, where they have moderate symptoms, moderate difficulty in social, occupational, or school functioning. So maybe this is a child who is truant on occasion from school. And if you work with this child over time, hopefully you can get that child up to an 80 or maybe even an 85. Wouldn't that be fantastic? One of the criticisms of the GAF score, if you look at the 91 to 100 range, is this realistic? How many individuals experience superior functioning in a wide range of activities and life's problems never seem to get out of hand? How realistic is that? Probably not all that realistic.